Yeah, I'll get started. So, hi everyone, my name's Kirsty. I'm a tissue revenue nurse specialist here at Coloplast, and I've got Charlie with me this evening who will be manning the chat. So if you've got any questions for us, just pop it in there. I can't see the chat because I'm sharing my screen, so Charlie will let me know if you pop anything in there. So tonight you're joining us to cover our three-step approach. So we are looking at making life easier by implementing a simplified framework into clinical practice. So tonight, the objectives are that hopefully during the session we will introduce you to the Coloplast three-step approach, which is a step-by-step framework that will help you effectively assess, prepare, and treat wounds. You will learn a simplified approach to wound healing, gain an overview of the impact and the costs associated to managing wounds in the UK, discover the benefits you can achieve from implementing a simplified framework, and leave with the three-step approach pathways to help support you in practice. So we know that in the UK, the impact of chronic wounds is really significant. Julian Guest did some data back in 2017, 2018 that indicated that 3.8 million patients with a wound are managed by the NHS annually. And that equates to 8.3 billion in an associated cost to manage these wounds. And only 6% of that is attributed to actually the wound care products. Everything else is down to things like nursing time, antibiotics, wound swabs, things like that. And we know that wound healing can be complex, and that's demonstrated obviously with the numbers that you see in there from on the previous slide. But we know that there is no one set demographic that means that a patient can get a wound. Anybody can get a wound and suffer from a wound. The wound prevalence is increasing. There's more wounds out there. There's more people suffering with wounds. There's no funding associated necessarily with wound care. And as we it's 8.3 billion to treat and manage these wounds. The workforce in the NHS is decreasing and the workload is increasing, so that's putting more pressure on wound healing and wound assessments, and resources are becoming depleted as well. So we've developed a three-step approach to help simplify wound healing and simplify wound healing practices. So with step one, you'll assess your wound. We would utilise a holistic and wound assessment, which is paramount in defining your treatment objectives. Step two is where you would prepare the wound, which is key to removing barriers to healing, creating the optimum healing environment. And step three is where you would treat your wounds with a simplified portfolio of dressings to manage the wound at any depth at any stage of healing. So when we're looking at wound assessment, the aims of a wound assessment is we want to identify the cause of the skin breaking down, because that can give us a lot of indication to what's going on, like the underlying reason. So for a leg ulcer or a pressure ulcer, for example, we then want to correct and treat that underlying cause because that's going to help us with the wound healing. We also want to identify any associated risk factors that might delay healing, identify appropriate management options, control wound-related symptoms. We also want to prevent any further skin or wound deterioration. We need to identify the patient's expectations as well, because there's patients out there that have had their wounds for multiple years that might not ever see their wound healing, and they might just simply want to get some of them wound related symptoms such as odor or exudate levels down to a more manageable level so that they can have a better quality of life. So it's identifying them expectations so that you can get some concordance. We also want to be providing psychosocial support and promoting patient independence with supported self-management where we can. And wound assessment can be complex with reasons for this being multifactorial. There's all different things that you've got to factor in when it comes to your wound assessment. You've got to factor the patient, the wound itself, any educational needs of your colleagues, and any organisational factors as well. But if you utilise a framework such as the triangle of wound assessment, where you look at the wound bed, the wound edge, and the peri-wound skin, it can help simplify the process by breaking it down, and then you're able to look at what treatment objectives that you'd require. Step two is then wound preparation, where you would prepare the wound by cleansing and debriding prior to applying a dressing. And what we've found is that it's been clinically proven that cleansing, debriding does speed up wound healing. So the screen that you've got on at the moment is a snapshot from the Wilcox study that was done in 2013, which was done on multiple wounds over a prolonged period of time. And what they found was that in diabetic foot ulcers, if wounds were debrided a minimum of once a week, the median time for healing was 21 days, whereas if wounds went 2 weeks with only one episode of debridement, the average wound healing was 76 days. So it is a quite considerable difference if you do wound preparation and debride your wounds to if you don't. Then step 3 is treat. So you want to be identifying then treatment objectives that you found in your wound assessment, and obviously and then following your wound preparation. And you want to be aiming to support an optimal healing environment for the wound. What the treatment objective will be different from every patient. It may be different from every time you assess that patient with the wound. So you want to be looking at managing and preventing exudate and exudate pooling. You want to protect the peri-wound skin. You want to be stopping any maceration or excoriation to the wound bed and the wound edge and the peri-wound skin. You want to be also looking for the depth of the wound and if there's a cavity, because that, depending on what product you decide to use, what dressing you decide to use, can obviously cause, the exudate pooling. It can cause maceration. Then you want to be protecting the skin, and you also want to be looking if you need to be treating and any signs of infection. So at Coloplast, we are really lucky that we have a couple of patient-facing nurses that run a clinic, and that's one of them on the screen there. That's our colleague Rommel. And what we did was we've started the wound care partnership program at Coloplast a couple of years ago, where we did run clinics and we utilised this approach of the assess, prepare, treat, and the Coloplast three-step approach in these clinics. And what we found is we were getting anecdotal data from ourselves in clinic and our NHS partners who were already utilising the three-step approach and the pathway and the framework, to see that we were getting accelerated healing time. So what we decided to do is we decided to look and analyse and audit these findings properly. So I was fortunate enough to have a clinic myself up in the northeast, and we looked at my patients there to see what the difference it had utilising the three-step approach, and we looked at some of Rommel's patients as well. So we implemented this simplified framework into our clinical practice. So we did have a multi-centre evaluation. We are currently recruiting 200 patients for this study, but when we hit the first 60 patients, we found that the results were that incredible that we needed to kind of get ahead and publish them early and get them out there for you guys to see, so that we can help you simplify your wound healing. So the inclusion criteria for this evaluation was patients that had non-healing wounds over 2 weeks, and the practice nurses in where we ran the clinics in the GP practices referred them to ourselves. We then completed a full holistic assessment, and we also did a wound assessment following the triangle of wound assessment, which is that wound bed, wound edge, peri-wound skin. Based on that, we then did wound preparation with all prep pad, and then we looked at the treatment objectives and treat the wound with a biotin product as the primary dressing. What we then did was we did a wound assessment and collected data at 2 weekly intervals until the wounds were healed or until at point of publication. So we assessed the wounds at 2, 4, 6, 8, and so on and so forth. There was some exclusion, so we didn't look at acute wounds. We didn't look at wounds that had any suspected malignancy or anything with small cavity wounds such as pynoidal sinuses and burns. They were excluded from the data collection. And these are the results that we found, and I'll break them down for you now. So overall, we found that the average wound healing duration at prior to implementing the three-step approach was 55.2 weeks. And following the implementation of the three-step approach using all prep pad and a biotin product, we found that wounds went on to heal in 6.6 weeks. And at the time of publication, 80% of the patients had healed. But one of the other considerable things that we found was that 53.3% of these patients received, of these 60 patients, received a course of antibiotics in the 6 months prior to taking part in the evaluation, which averages out about 1.5 courses per patient. But what was amazing was that no patients throughout the evaluation had any antibiotics during the period of being in the evaluation. We've then also broken the wounds, the data down to look at legs and non-leg wounds. So in the non-leg ulcer wound category, we found that these wounds had an average baseline duration of 9.85 weeks. And this is because of the nature of the wounds. We were looking at skin tears, bites, there was I think there's a pressure ulcer in there. So we've got different wounds in there. So you can think about the nature of the wound. That's why they've got a drastically different wound duration baseline. But these wounds went on to heal in 6.8 weeks, and 100% of these patients healed. And again, none of them had antibiotics. And this is just one of these patients here. So this is a patient from my colleague Rommel, who you saw on the screen before. And this is an 81-year-old gentleman who had a category 2 pressure ulcer on both buttocks, and he'd had them for 2 years. They were having significant impacts on his quality of life, and he wasn't being able to do his usual activities such as ballroom dancing, classes with his wife. He was unable to sit down, lie down, or rest properly. So if you can think of the considerable impact that would have on you, I mean, just one night not getting a good night's sleep can make you feel rotten. So if this man's had this for 2 years in a constant cycle, the wounds had 100% dark granulation tissue. There was moderate volumes of exudate coming from the wound, and it was suspected that because of the duration of the wound being over 2 years, that there was a biofilm related wound infection there as well. As you can see on the photo, on the first one, you can see the peri-wound skin looks really fragile, and there was also extensive burn scar tissue from a burn that he'd sustained as a child. So that has the risk of breaking down again, because our scar tissue is only about 80% as strong as what the tissue was there originally. So it's got a risk of this wound had a risk of breaking down further. So Rommel utilised a three-step approach on this patient, and he used all prep pad for wound preparation, and biotin silicone was implemented following the first appointment. At the patient's request, and due to the area, the anatomical location, the wounds were prepared and dressed 3 times a week, whereas in most of the cases of the other 59 patients that were involved in this cohort, the wound dressings were only changed, and wound preparation was only performed twice a week. Because of the nature of the simplicity of the pathway and of the three-step approach pathway and of the products, supported self-management was implemented with the support of the patient's wife. So all prep pad is ergonomically designed so that patients can use it themselves. And because biotin can offer that 3D fit technology, you only need to use it as the primary dressing. They were able to follow that simplified pathway. The patient's quality of life improved, and he was able to go back to his weekly ballroom dance classes and his usual activities, and he had no anxiety over the wound leaking. He wasn't in any pain. He wasn't concerned that, if he sat down for a certain length of time, that it would cause deterioration. And he went on to heal in 4.5 weeks with no complications.
Kirsty?
Yeah.
Hello, it's Charlie. Could you just explain what the 3D fit technology is for those that don't know, please?
Yeah, so I'll go back to that slide. So 3D fit technology is in our biotin silicone product, and what it does is when the silicone foam comes into contact with exudate and comes in contact to the wound, but it conforms to the wound bed. So if you've got a wound that's going and delving, and that conforms up to 2 centimeters, it'll conform down and kind of lay in the wound bed nicely so that it doesn't form a gap, so that the exudate can't pool, and then it'll absorb it and lock it away, so that it doesn't leak out onto the peri-wound skin as well. Is that okay?
Perfect, thank you.
So the National Wound Care Strategy Programme say that healing rates for venous leg ulcers suggest that at least 75% of individuals with venous leg ulceration uncomplicated by other conditions should heal in 24 weeks. But what we found with utilising the three-step approach is that overall, patients with leg ulcers, whether or not sorry, the dog's just started to bark. Overall, these patients, whether or not they're simple or complicated, they went on to heal in 6.5 weeks, and 79% of them healed at the point of publication. And these patients had an average wound duration of 73.2 weeks prior to being involved in the publication. So if I go back to this slide, like it says on the slide, it says they're uncomplicated by other conditions. So we have then also broken down the data further to look at simple and complicated. And I'll come on to the complicated category in a second. But for the simple leg ulcers, these had an average wound duration of 8.75 weeks. They went on to heal in 3 weeks, and 100% of the patients healed. So if this is, we're looking at the category that the National Wound Care Strategy have said, they had 75% healing in within 24 weeks. Following the Coloplast three-step approach, we've got 100% of patients healing in 3 weeks with leg ulcers that aren't complicated by other conditions. So it's a considerable difference in a length of time. But what's interesting is the terminology uncomplicated by other conditions, obviously, as clinicians, we wanted to unpick and know what that meant more. So we did a literature review and looked at what is everyone saying of what a complicated or a complex leg ulcer is, and no one will actually define it. There isn't actually a definition out there to say what is classed as a complicated or complex leg ulcer. So we did a literature review. We then RAG rated the results of that. And what we found was that in all the documents and the publications out that we looked at, what was common was that if it was defined as a complex leg ulcer, they had a wound surface area of over 100 centimetres squared, which sounds huge, and it is big if you think about it on a leg, but that's 10 by 10. They had their wound for roughly about 6 months, for 6 months in duration. It had not improved or reduced by 40% within 4 weeks following best practice. So that would be obviously your 40 milligrams of mercury compression. They had an abnormal ABPI, which was outside the range, or they couldn't get a reading. They had a current infection at the time of assessment, or they'd had history of multiple infections, a history of non-concordance. There was an active ulcer with one measurement between 2 and 6 centimetres. And I know that there's 2 measurements on there, but based on the RAG rate, we had to kind of include it because it came up with the same number of times it had been referenced in documents. And the other thing that classified something as a complex leg ulcer was comorbidities, including peripheral arterial disease, diabetes, sickle cell anemia, self-harm, intravenous drug use, rheumatoid arthritis, and if they were immunocompromised or if they had mobility restrictions. And what we found was in this category of patients, they had an average wound duration of 39.23 weeks, but they went on to heal in 6.3 weeks, and 91% of them healed. And obviously none of the patients had antibiotics, which really lends to, antimicrobial stewardship. So if this National Wound Care Strategy is saying 75% uncomplicated healing 24 weeks, we've got 91% healing in 6.3 weeks by following the Coloplast three-step approach. And this is one of the patients here. So this is a patient of mine. This is Sandy. She's a 55-year-old female who unfortunately got a venous leg ulcer following a fall. She slipped in a garage and fell into something, which caused the break in the skin. As she had a chronic bioburden, she was in constant pain. She had high exudate volumes, which you can kind of see on that first photo there. You can see it pooling in the wound. And there was a malodor coming from the wound. It had significant impact on her quality of life. This was a lady that was still working full time. She was also a carer for her mum and her sister, and she was a hands-on grandma to a 3-year-old as well. So there was a lot going on, and she wasn't able to do all these things properly. She did self-manage at home for 4 weeks prior to coming and seeing her practice nurse because she suffers from white coat syndrome quite significantly. But she then had she did come for twice weekly appointments with myself. We did the full wound assessment. We looked at the wound bed, which you can see there. It's covered in slough. There's devitalized tissue in there. The wound peri-wound skins also, you can see it's excoriated from the exudate levels that are coming out. Because of the wound depth, I had to utilise biotin alginate AG and then cover with a biotin silicone, so that gap was managed so that we didn't get that exudate pooling that you can see in the first picture. She did have twice weekly appointments with myself, and where the 3-step approach was implemented. Doppler was completed within 3 weeks, and the reason why we had to wait 3 weeks was because, like I said, this woman still worked full time and had a lot on. So trying to factor that in to get the Doppler was an issue. So we were slightly behind what the best practice is saying of getting a full leg assessment within 2 weeks, but she worked full time, so this was the best that we could do. And then because of issues, as some of you are probably aware of, FP10s and getting the prescription and then waiting for the product, we actually didn't start compression hosiery until week 4. But what's amazing and what you can see on the photos is you can see that depth of that wound coming up significantly in them first 4 weeks before she got into compression therapy. So by the time we did get to week 4, we weren't needing to use the alginate AG or any sort of filler to pack the wound because that 2 centimeters had come up. So we were able to use biotin silicone and conform to the wound bed. And because of that, by week 6, she was able to utilize supported self-management. So she was able to prepare the wound using oil prep pad herself, and then using the biotin silicone to dress the wound as a primary dressing, and then wear a compression hosiery over the top. And she was fully healed by 13 weeks. I have, over the Christmas, just before Christmas, bumped into Sandy because she lives relatively close to where I do, and she is still healed. She has a tiny little scar, and as probably most of the patients do, is she's no longer wearing a hosiery, so she's not concording there. But the good thing to know is the wound hasn't broke down. She hasn't had a reoccurrence, and she has still remained healed. While we were looking at patients that fell into that complex leg ulcer category, we found about 7 patients that stood out more than what they did in others. And that came from my line manager at the time coming to spend time with me in my clinics. And we found that we were getting these accelerated healing rates of 6 weeks, but there was a couple of patients that she kept seeing all the time when she kept coming out, and we wondered why that was. So we looked at these 7 patients against that complex category. What we found was that these patients had 4 or more and ticked 4 more than boxes of that category, but they all had issues with their mobility. So we've deemed these patients as an increased complexity leg ulcer category. And in this cohort of patients, they have an average wound duration at their baseline assessment of 341.1 weeks. And there was one patient that was involved in that number that had had his wound since 2002. And he came in and first saw me and he was like, I'm going to die with this, but is there anything that you can do so I'm not changing the dressing twice a day because I can't do it anymore? And his wound actually did go on to reduce by 25%. While I was seeing him, and he got his dressing changes down to twice a week. One of these patients at time of publication did go on to heal, and they healed in 26 weeks. And none of these patients, if you think of the complexity that they will be under, had any antibiotics during the evaluation period. And we, as I said earlier on in the webinar, we are currently on the road to getting 200 patients involved in this evaluation study. And we are looking at the data constantly. And just before Christmas, I did look, and more of this category have gone on to heal. So look out for that when we do publish the 200 patient results. This is one of these increased complexity patients. This is a 52-year-old female that had a history of intravenous drug use and mental health problems, and she presented with multiple venous leg ulcers. They were bilateral, and they were on both medial and lateral aspects of both legs. When she first came to see me, she said that she'd had the wounds for about 7 years. However, when we started to look back over system one, there's a possibility that the wounds are actually about 16 years old, because she's had mental health problems and because she has a history of non-compliance, and she's not concordant at times. There's been gaps in where she's been accessing her wound care in general practice, because she's been admitted to the acute services, she's been admitted to mental health services, so she's just not complied at all because of her drug use. And what we found was that wounds are always documented to be in the same place. So if she had achieved healing with any of them, they've not healed for long, and they have reoccurred. Like I said, she had a history of non-compliance. She's tried multiple different wound management regimes. You name it, this woman will have tried it. I tried on numerous occasions to get her to have an ABPI and try get into some sort of compression therapy, but she refused because she'd had previous negative experiences. She'd had 32 wound swabs and 48 courses of antibiotics just from her GP practice alone. That doesn't include what she would have received through mental health or through the acute services. And these wounds were having huge implications on her quality of life. I first saw this lady over the coronation period, and she was supposed to go out for a family afternoon tea to celebrate, and she refused to go because she was that embarrassed about the smell that was coming from the wound and the amount of exudate. And the exudate was that bad that she was wearing 2 pairs of trousers to hide what was leaking out, because it just wasn't being absorbed into the dressing. So she came for twice weekly appointments with myself, and most of the time, I must admit, she did follow the 2 weekly appointments. She did stick to it, and we did get to a point where she was confident enough that she was participating in sort of self-supported self-management. We utilised the all prep pad. Because of the high volumes of exudate and the depth on the wound when we first started, we did have to utilise alginate AG and then the biotin silicone, but we were able to drop down to just the silicone once we got them exudate levels under control. And by 39 weeks, the wound had reduced by 70%. So this is a wound that was potentially 16 years old, and we'd reduced it by 70% in less than a year. But if you actually look on the pictures, there is a wound to the top of the ulcer, like another ulcer that did go on to heal. But the biggest takeaway I think that we all took from this patient was that she got to the point where she wasn't wearing 2 pairs of trousers because there was the exudate volumes were normal and there was no odour. And she actually went out and bought herself a push bike, because she wasn't suffering with immobility, because the pain had got better as the wounds healed as well. So it had major impacts to her quality of life improving just by following the 3-step approach. And these are just some of the comments that we've had from patients that have took part in the evaluation. The one on the that says all prep pads make my legs feel so clean and fresh. I asked a doctor to amputate my legs because of these wounds. If you would have asked then if I'd ever seen these wounds healed, I would have said no. And look at them now. It's down to the tissue viability nurse specialist and the Coloplast 3-step approach. That quote is from Jane, who I've just showed you as well. She did actually ask for legs to be amputated because of the wounds. So huge impacts in quality of life that we've seen. We've patients ruining their life, wanting to take their own life, and they've got their spark back. So if anything, yes, okay, we're seeing accelerated healing results, we're seeing AMS, and we're seeing no antibiotic usage by following it, but we're getting massive results from patients to say that they've seen the benefit in their quality of life. So by simplifying wound healing with the Coloplast 3-step approach, all patients underwent a thorough and holistic wound assessment from a tissue viability nurse specialist. The care was standardised based on the three-step approach and the simplified portfolio of Coloplast wound care products, so all prep pad and a product out of the biotin range. And what we found was it promoted shorter healing times, it improved patient outcomes and had massive implications on their quality of life, and there was no antibiotic, there wasn't less antibiotics, there was no antibiotic usage while they were taking part in the evaluation. So like we've gone over, through following the three-step approach by Coloplast, you can simplify your wound healing through your assessment with your holistic and your wound assessment to define your treatment objectives. You then do step 2 to prepare, where you remove the barriers to healing, creating the optimal healing environment where you'd utilize all prep pads. And then step 3, following your assessment, following your preparation, you'd use a simplified portfolio of dressings, such as biotin, silicone with 3D fit technology to manage the wound. And then as well, by utilising 3D fit technology, you're able to implement supported self-management as well. So we have developed some pathways that are etiology specific, can't get that word out at nearly 7 o'clock at night, that follow the assess, prepare, treat pathway, but also specific to wounds in general. So there's ones for wound infection, there's pressure ulcer, there's leg ulcers, there's skin tears. And we'll give you a link, a QR code at the end where you can ask if you would like more. But they all follow this 3-step approach and can support and guide clinicians to utilize them and get them simplified, to that simplified approach to get them healing results. And on the back of them, we also offer product selection guides where you can simplify your product choice. So you can follow the pathways, you can utilize the pathway, and then the results will then give you what products would fit best for you to have that simplified approach, where you can use, maybe you can just use 1, 2, or maybe even just the 3 dressings if it is over 2 centimeters deep, where you would need a filler. So like I've just said, we'd offer the QR code. So if you do need any additional support with any of our products and services, we can offer a follow-up telephone call for you to discuss, and we can arrange face-to-face or virtual education. So if you just, you can submit your details, or you can just scan that QR code, and we will be happy to help and answer any of your questions. Charlie, who is my lovely assistant tonight, also with our colleague Sam, have offered some podcasts which are available on Spotify, Apple Podcasts, Google Podcasts, where you can listen and learn more about wound healing from expert tissue viability nurses. So we've got podcasts on assess, prepare, treat. We've got ones on wound infection, pressure ulcers, leg ulcers, and supported self-management. And I do believe there'll be more coming in the coming months as well. So that's everything from me. Is there any questions?
Brilliant presentation. Thanks, Kirsty. We haven't got any questions in the chat at the moment. I would just like to reiterate that there will be a copy of the recording available after the webinar, and we'll also send you a link to the full publication along with a certificate, so you will receive those. And there's also a link in the chat for the follow-up call if you missed the QR code.
If has no
anyone,
one's got...
yeah. Go on,
I was going to say, if anyone got any questions,
yeah.
If anyone wants us to discuss anything anymore, please just shout out. We're happy to go over it.
No, they've all been very quiet.
Yeah, very quiet. Well, if no one's got any questions, thank you everyone for listening and joining. As Charlie said, we'll send out your certificate and some supporting materials, and that QR code is there and the link's there if you do want any further information.